Today we will talk about the shoulder complex with a review of anatomy and also common dysfunction of the shoulder. Speaking specifically of the shoulder joint, it is a ball and socket joint that is formed by the glenoid fossa of the scapula and the head of the humerus. You can see the reminder there of the humerus will be moving on the scapula, which would be convex on concave rule, which we'll discuss in the next slide. The shoulder allows for multiplanar movement in all planes of shoulder flexion, extension, rotation, internal and external, as well as AB and adduction. Something to take note of is that the glenoid fossa is relatively shallow. That is why there is the addition of the labrum, but also it allows for lots of mobility of the shoulder. And whenever we have lots of mobility, what do we give up? Stability. I do want you to review your anatomy of the humerus and the bony prominences and the importance of these. If we think about even where the bicipital groove with the long head of the biceps traveling along that groove, what other muscles attach at the greater and lesser tubercles, and it is a common fracture site to be occurring at the surgical neck of the humerus. But let's talk a little bit about the arthrokinematics of the shoulder joint. If we talk about the humerus, you see the humeral head is our convex surface moving on our concave of the glenoid of the scapula. So if we think of convex on concave, that means that the roll and the glide of the joint are going in opposite directions. So if we think about the roll is always going to go in direction of the humeral shaft. So let's go through all of them. If we say shoulder flexion, the roll is going to be in the anterior direction, just like how the humerus is moving anteriorly, and the glide will be posterior. If we talk about shoulder abduction, when we abduct the shoulder, the roll will be in a superior motion, just as the humerus is moving superior, and the glide will be inferior, opposite directions. So if we want to talk about if this is limited, this motion is limited, we could do a joint mobe. And so what direction would we do our joint mobe? So let's talk about we're limited in shoulder abduction. A lot of times that the glide will not be able to occur inferiorly because of a restriction in the joint capsule. So the joint mobe would be an inferior glide. I want you to think about the arthrokinematics for both internal external rotation as well as shoulder extension, and jot down the which direction is the roll, the glide, and what would you joint mobe if it was limited. And we will discuss these in class. This is another slide of reminding you of the importance of knowing your bony anatomy as well as your muscle attachments. As we continue to do palpation, and when we can palpate something and find that it causes pain or is tender, it can really help us with the diagnosis of what is going wrong. For example, here it shows you the medial and lateral epicondyles of the humerus are attachment sites for the wrist flexors and extensors. And so that is often, if people have medial or lateral epicondylitis, you hear the itis, meaning that inflammation of that area, it is often the attachment of those muscle tendons that are inflamed. And we'll talk much more about epicondylitis when we get to the elbow. Our shoulder complex is actually made up of 4 different joints. The sternoclavicular, the acromioclavicular, the glenohumeral, which we've already been discussing, and then the scapular-thoracic, which is actually more of a functional articulation where it's holding the scapula to the thorax. And we will discuss these more, especially when we start to talk about forced couples. The sternoclavicular joint is another joint within the shoulder complex. It is a shoulder joint, it is a saddle joint with an articulating disc. It allows for 3 degrees of movement, which are described if we look at the lateral end of the clavicle. It allows for elevation and depression, which occurs during shoulder AB and adduction, along with the scapular upward and downward rotation. It allows for protraction and retraction, which occur with horizontal AB and adduction of the shoulder and protraction and retraction of the scapula. And then also allows for anterior and posterior rotation, which occurs with flexion and extension of the shoulder. You also see listed there as a reminder of the ligaments that are at and supporting the sternoclavicular joint. The acromioclavicular joint, also within the shoulder complex, is a synovial joint, and it does have a slightly convex surface of the clavicle on concave surface of the acromion. However, we will just discuss the osteokinematics and not the arthrokinematics of what's going on at the joint, just like we did for the sternoclavicular joint. So the acromioclavicular joint has 3 degrees of motion with upward and downward rotation, which occurs with shoulder AB and adduction and upward and downward rotation of the scapula. It has protraction or retraction, which occurs with the protraction and retraction of the scapula, as well as horizontal AB and adduction of the shoulder joint. And it has anterior and posterior rotation, which occur actually with the tilting of the scapula, both anterior and posterior tilting. You also see the listing of the ligaments at this joint. Here you have a sagittal cut or sagittal view of the actual shoulder joint and seeing the glenoid fossa and the labrum, and has a review there of muscle attachments within the area. And then on the other side of the slide you see an intact joint capsule with the head of the humerus visible within the capsule. And I think that this is a good picture to see that if there are some restrictions or tightness within that joint capsule, maybe after immobilization, you could see where the humeral head would be limited in its movement. And actually there are different patterns that you see that will tell you or will determine that the joint capsule is the problem for the restriction. So we call these capsular patterns. And for the shoulder joint, you would find greater limitations in external rotation, followed by rotations in abduction, and then less restrictions in internal rotation. This slide shows you the reinforcement of the shoulder capsule, and you see the ligaments, the superior, middle, and inferior glenohumeral ligaments. Bursa within the shoulder joint are fluid-filled sacs, which are there to reduce friction during movement. You see 3 bursae described or listed in the picture, which is the subdeltoid, subacromial, and subcoracoid. And in the picture you can see that the subacromial bursa is inflamed, probably due to shoulder impingement, or maybe part of the cause of the shoulder impingement and the pain that the patient is having. This slide is a summary of the shoulder complex as we've been discussing already. Again, it is a multi-axial or has has movement in all planes of motion. So it is a very movable joint, and when we have lots of movement, we are then going to have decreased stability within that joint. Although we do have several structures that try to provide stability, the joint capsule, and then also we have the labrum within the joint that provides more surface area for the joint. And we also have muscles and tendons. The long head, the biceps, inserts with the labrum, and to help prevent movement of the humeral head. The rotator cuff muscles also work to position the humeral head during shoulder movements. We have ligaments that stabilize the actual joint capsule, as well as ligaments within all of the joints within the shoulder complex. We also have synchronous movement or muscle firing of multiple muscles in that area to have what we're going to be discussing in the upcoming slides of forced couples, of how these muscles work together to accomplish the movement. We also have scapular-humeral rhythm, which is in a 2-to-1 ratio. You can find a good description of these on your Daniels and Worthingham book on page 83 and your Mansfield and Newman book from last semester on page 59. But what it refers to is that the humerus will move 2 degrees or as the humerus moves every 2 degrees, the scapula will have upward or downward rotation with every 1 degree. So if we talk about the 180 degrees that are possible for shoulder abduction, the humerus or the glenohumeral joint is going to have 120 degrees of that movement, where there will be 60 degrees that's going to come from the scapular upward rotation. Since the shoulder complex is a four joints that work together to provide the mobility of the shoulder, there are groups of muscles that must work together to achieve these motions. And these muscles will attach on the spine, scapula, the shoulder joint. And so that's why a lot of times when our patients can have symptoms or pain with shoulder movement, and we think about looking at the glenohumeral joint, the origin of the pain could actually be coming from the cervical spine because of muscle attachments to the cervical spine. And so it's something that we really must consider. And, through this course that you're taking this semester, you'll be able to look at the ranges at the joints above and below and help to determine if maybe the issue could be the cervical spine or, the thoracic spine instead of just the shoulder itself. Here are some examples of force couples within the shoulder complex. The deltoid muscles as a group and the rotator cuff muscles work together to accomplish shoulder flexion, abduction, and extension. As the deltoid causes the movement of the humerus in these directions, the rotator cuff stabilizes the humeral head within the joint so that we do not have impingement occurring. The trapezius, both the upper and lower, as well as the serratus anterior, work together to accomplish upward rotation of the scapula. And then the rhomboids, levator scap, pec minor, and latissimus dorsi all work together to accomplish downward rotation of the scapula. As already stated, how those rotator cuff muscles, they cause an increase in tension, and they center the humeral head within the joint, within the glenohumeral joint, so these motions can occur. Scapular stabilizers are those that are accomplishing that movement on the scapula itself. One of the main scap stabilizers is the serratus anterior, which performs protraction of the scapula, and its attachment on the medial border of the scapula actually keeps the scapula in contact with the thorax. So if somebody has a weak serratus anterior, we will see winging of the scapula, and maybe we'll see this in one of your classmates in lab. Also, you see that there is a video for you to watch that shows some of these force couples. I have placed this video under this module on Blackboard so that you can watch it at your leisure. On this slide, we'll put together your knowledge of anatomy that you learned last semester and what do we see functionally in our patients. So there's just some little tidbits here. So if we say if there's an injury to the long thoracic nerve,
we will see winging of the scapula. And why is this? That's right, because the long thoracic nerve innervates the serratus anterior. So if we have injury to that nerve or that part of the brachial plexus, then we are going to have see winging of the scapula. Here's another one too. So if we have the dorsal scapular nerve is impaired, we're going to see that the patient is not going to be able to retract or downwardly rotate the scapula. And why is this? That's right, it's because the dorsal scapular nerve innervates the rhomboids and the levator scap. So if we talk about the suprascapular nerve, we can have impingement at the suprascapular notch, and it can cause pain and impairment with abduction, as well as flexion and external rotation. And why is that? Yes, because the supraspinatus and the infraspinatus muscles are innervated by the suprascapular nerve. If we talk about the subclavian artery and vein, this actually can be compressed as it travels through the anterior and middle scalene muscles. It's also can be, if there's a presence of a cervical rib, it can cause compression of these. And so tightness in these muscles or the presence of a cervical rib can compress these arteries. And we're going to see then symptoms of numbness, tingling in the upper extremity due to lack of blood supply. And this is actually called thoracic, in my day it was called thoracic outlet syndrome, and you'll still hear therapists refer to it that, or physicians, but now it is more called thoracic inlet syndrome. We'll discuss this in more detail when we get to the cervical spine. We will now discuss some common shoulder conditions and clinical interventions. Acromioclavicular joint sprains involve the AC, or the acromioclavicular ligament, and the coracoclavicular ligaments. The mechanism of injury usually occurs either with a direct fall or force to the joint, that superior lateral surface of the shoulder, or I think more commonly it occurs if there's a fall on an outstretched hand where the transfer of force goes from the ground all the way up to the AC joint, which will then have the disruption of the ligaments. There are 3 grades of these ligament sprains. The first one is more mild. It really only involves the AC ligament and may have a partial tear within that ligament. There is usually no displacement of the clavicle. Patient will have pain, and usually they are going to be immobilized, but it might be a period of 2 weeks until it is recovered. Most of the time we will not see patients who've had a grade 1 sprain. Grade 2 is where the AC ligament is actually disrupted or torn, and there's some partial tearing of the coracoclavicular ligament. You'll see some displacement. You'll actually be able to palpate a step off from the clavicle to the acromion. Patient is going to have pain. This patient will be immobilized for a longer period of time. And then the grade 3 is going to be a complete disruption of both ligaments, and you see that in the picture to the side. They are going to have displacement of their clavicle. They're going to be very painful. They are probable for a surgical candidate where they would go in and do a fixation, either a pinning of the joint, or they may even try a conservative management of physical therapy and to see if through immobilization and then followed by muscular strengthening to see if normal function of the shoulder joint can return. So the clinical management is going to obviously vary depending on the severity of the sprain. Like I said before, grade 1, we're probably not even going to see them in physical therapy. But the beginning points of all of treatment for all 3 of these grades is that first it's going to be immobilized, allowed to rest, using modalities to decrease inflammation, and also I'm sure the physician would prescribe some type of anti-inflammatory medication. And then we're going to gradually increase through adding some range of motion exercises, maybe active assisted range of motion. And range of motion is going to be in that pain-free range initially. And then we'll progress to some strengthening, starting with isometric and then going to more functional strengthening. We will practice some of these or just discuss some actual specific exercises that you would want to do with your patient when we are in lab. Glenohumeral instability or shoulder dislocation can occur both in the anterior and posterior direction. And often once a dislocation has occurred, it is more likely to reoccur again unless there has been some surgical intervention. The anterior dislocation is going to result from forceful abduction, extension, external rotation. And this is the most common direction of dislocation. And if we think about the direction, if we look at the arthrokinematics, let's say of external rotation or extension specifically, those two motions combined together. When we have extension, we're going to have the roll and the arthrokinematics in the same direction, so it's posterior, and then the glide is anterior. So that's that mechanism of injury. If we're going to have forceful extension, external rotation combined, then we're going to have that stress on the anterior portion of the joint capsule and can result in dislocation. If we can also, with the anterior dislocation, have a Bankart lesion, which is when there's an actual tear or avulsion of the joint capsule or the labrum, and then also the Hill-Sachs lesion, which is a fracture of the humeral head due to that forceful dislocation. Could also have a posterior dislocation, which often results more from adduction, flexion, internal rotation. This is not very common, but you can have the reverse Hill-Sachs, which again would be that impact fracture of the humeral head. And sometimes we'll also have rotator cuff tears along with this dislocation. Patients will be immobilized, usually in a sling. They'll have lots of muscle guarding and weakness. And depending on the severity or the frequency of the dislocation, may have a surgical intervention for stability. Or if the labrum has been torn, we can also have that surgically repaired. During the PT's evaluation, you will probably see apprehension tests, and we will show this special test in lab, but it would be showing you a positive sign for possible shoulder dislocation. So again, the clinical management is going to be immobilization. Why it's important to remember that why a patient's shoulder is immobilized, we could have movement at the elbow, wrist, forearm, and hand. Because we could have a complication if our patients were to stay in their slings and not move the distal joints, then we could end up having limitations within those joints as well. So it's important as a PTA to make sure that that patient feels comfortable coming out of their sling in a safe seated position and performing range of motion distally. After our patients have been immobilized in a period of where we are now able to do some active movement, we will progress passive to active assisted range of motion to full active range of motion. It's going to be very important in the early parts of rehab that we are avoiding the motions or the directions the dislocation occurred. So if it was that anterior dislocation, we are going to avoid initially abduction, extension, external rotation. We will progress to those, but we're going to allow more time for healing and strengthening around the shoulder joint. When we talk about strengthening, we are going to begin with isometrics. And we're going to make sure we want to rehab the rotator cuff muscles as well to make sure that we have the good shoulder mechanics. And here's some examples that you may want to do: some cable systems, TheraBand. You are going to progress to close chained exercises. And the idea that this recovery may take up to 4 months and possibly longer if surgery has occurred. Shoulder or capsular surgery repair is surgical intervention for unstable or shoulder, usually occurring after dislocation as stated in the previous slide. If this has occurred, our patient is going to be immobilized in the sling. The management or the clinical management of this condition is often divided into 4 phases, where we have controlled motion, strengthening, advanced strengthening, and return to function. So as we discussed earlier, in our controlled motion, we're going to do active range of motion of the joints distal to the shoulder, so that while the patient is immobilized in their sling, they are not going to develop any range of motion limitations distally, just due to immobilization. And it can also begin with Codman's pendulum exercises, maybe a little bit of pulleys, up to maybe only 90 degrees or 60 degrees of 90 degrees of flexion, 60 degrees of abduction. We'll do active range of motion in limited non-threatening range. So what does that mean, non-threatening range? So again, if we're talking about an anterior dislocation, we are going to avoid those extreme motions of extension and external rotation. And in this phase 1, you can also begin isometric exercises where the shoulder is going to be in a stable position and you're strengthening the muscles around. In phase 2 strengthening, we're going to progress and make sure that we do still stay pain-free. We're going to do wand exercises where you can do the flexion, abduction, and a little bit of external rotation. We're going to add TheraBand or maybe some free weights, again in that more straight plane motion to begin with. And then advanced strengthening, we definitely want to incorporate our eccentric strengthening, maybe changing the speed and combining motions as well. And the last phase is going to be return to function. And this is where we're going to have the patient doing closed chain exercises, maybe getting back to whatever activity they were doing before. If they're involved in sports and they're a thrower or a pitcher, getting back to those activities. Subacromial rotator cuff or impingement syndrome is when the elevation of the humeral head compresses the soft tissue of the subacromial bursa and the rotator cuff tendons between the head of the acromion and the coracoacromial ligament. It usually occurs with prolonged or repeated overhead activities. It may result from either a structural cause, which is what we consider primary, and that is the actual compression of the rotator cuff tendons. And then also it can be more of a functional cause, which is more secondary. Maybe there's instability within the shoulder joint and the rotator cuff muscles are weakened, and so that the humeral head has a lot more movement, which then causes compression. So anytime that we have that excessive superior gliding of the humeral head, there's potential for impingement of those tendons. They actually have 3 different stages of Neer's impingement. The first stage usually occurs in younger individuals, less than 25 years of age. There's probably some edema, some hemorrhage, irritation, but this is a reversible condition. They respond very well to physical therapy. Stage 2 usually occurs in individuals 25 to 40 years of age. There is some fibrosis of the tendons, and at this point it is considered irreversible damage, but can still work on rehabilitation of the proper muscle strengthening and firing to get decreased pain in this area. At stage 3, usually individuals over 40 years of age, there is going to be some tendon degeneration, but we can still do rehab again to get that proper alignment through strengthening and muscle activation. Signs and symptoms of impingement is going to be pain that increases with shoulder flexion and abduction of past 90 degrees. There's usually a painful arc that occurs between 60 degrees of motion and 120 degrees. They will be tender to palpation over this area, and they will often have radiating pain into their upper extremity. And they actually may even have a loss of their range of motion, and it can't even mimic those of a capsular pattern. There are positive tests that we can do in the clinic to see if they are having impingement. You see them listed there, and we will practice those special tests in lab. The clinical management for an impingement is at first, again, using modalities to reduce pain and inflammation. The physicians, again, may prescribe medication to decrease the inflammation, or they may even perform a steroid injection. We're going to try to avoid initially the motions that provoke pain, so we'll be doing things that are in a pain-free range of motion. We'll do isometric exercises to strengthen within that area, and then we'll progress to as it is healing and the inflammation is decreasing, we'll progress to those motions that initially caused pain. We'll do a lot of focus on our rotator cuff and making sure that we are having our scapula stabilized during these motions, and then we try to return these patients back to their normal function. If physical therapy is not successful in treating shoulder impingement, the patient may require a subacromial decompressive surgery to relieve the pressure. And what the surgeon actually does will go in and shave off part of the acromion so that the patient is no longer getting the impingement at that area. Sometimes also, as depending on what stage of Meniere's impairment, if they have had degeneration of the rotator cuff tendons, they may go in and do a repair of those tendons as well at the same time. And then rehab of someone who's had a surgical repair, and we have a guideline there of 3 different phases of rehab at 6 weeks, 7 to 12, and 13 to 21. But this will be dependent upon the surgeon. The orthopedic surgeon will often have a protocol of what they want therapists to follow once their patient has completed surgery. But again, it's going to start out, as we've talked about all these other conditions as well, that the first phase is going to be pain control, decreasing inflammation and swelling, and then maybe adding some passive to active range of motion exercises and pain-free range of motion. And then as we progress through rehab, we'll progress through the strengthening. Again, starting pain-free and then initiating those exercises that would have reproduced the pain of impingement before. We'll really focus on the strengthening of the scapular stabilizers and the rotator cuff muscles so that we can have that proper alignment and function of the shoulder. Fractures to the proximal humerus often usually recur as a result of the fall and can be seen even more often in patients who have a diagnosis of osteoporosis. They may involve fracture of the humeral head, the tuberosities, the necks, or the shaft. And that most common site is that surgical neck where the fractures can occur. The treatment may be, they may require surgery and have an open reduction internal fixation or a total shoulder replacement. Or if it is a non-displaced fracture, immobilization may be all what is needed for it to heal. These patients are often very painful. They're going to have difficulty with their ADLs, even just more so because of being immobilized and trying to negotiate getting dressed while having the big immobilization under their arm, the shoulder wedge. Clinical management is going to be dependent on to whether there was a surgical intervention, but again, it's going to begin with immobilization and then some gentle pendulum exercises. It is important too that we want to be doing some shoulder shrugs or some scapular retraction so that we aren't going to be disrupting the fracture by having movement focused on the glenohumeral joint, but for the shoulder complex so that we don't get lack of motion within the scapula itself. And again, our early on treatment is going to be doing modifications for our patients' ADLs so that they can become as independent as possible while they are immobilized. And then we are going to progress to isometric exercises and then passive active assisted range of motion exercises. And again, in these early on, while the fracture is still healing, we are going to make sure everything is pain-free. Again, while that patient is immobilized, we are going to do distal movements as well so that we don't get any restrictions at the elbow, wrist, or hand. after the bone is healed, and this can only be told to us through the physician after they have completed a radiograph to confirm that there is healing. At that point, you could do some joint mobilization if there's restrictions within the motion. I'm going to be doing a lot of stretching and strengthening, and we're going to also focus on what their function is and what do they need to do. And yes, we are going to try to regain full range of motion, but we also want to make sure that that shoulder is functional for that patient and what their prior function was. This may be age dependent as well. And you can see the length of time there, and that is depending on the severity of the fracture and what, if there was surgical intervention or not, but can take 3 to 6 months for recovery. A total shoulder replacement, or arthroplasty, is done often following trauma and the humeral fracture as discussed in the previous slide, or it can be through degenerative changes from osteo or rheumatoid arthritis. This is where they will use the prosthesis to replace the humeral head. And then we actually begin with active range of motion quite early, immediately post-op. And this is because there is no fracture that is healing, and so we can have active range of motion. One motion that is typically avoided initially would be external rotation, and that is to protect the subscapularis, which is an internal rotator. So as we were to go into external rotation, we would be putting a stretch on that, and specifically the distal attachment, which is on the lesser tubercle of the humerus. We want to protect this since we've just had the replacement and it's near that location. As mentioned, we are going to begin with active and passive range of motion right away. We're going to do isometric exercises for the rotator cuff. We'll have modalities for pain. Be able to do, and specifically looking at their scapular-thoracic joint mobilization so that we have that good scapular-thoracic rhythm that we want to develop and make sure that there aren't any adhesions binding down the scapula. And we're going to do a lot of scapular strengthening for all of our scapular stabilizers so that we can have that normal glenohumeral scapular-thoracic rhythm. Definitely want these patients to be on a home exercise program and even continuing after physical therapy has ended. Some patients may also have rotator cuff involvement, and that surgery may occur as well, and then their outcomes will take a little bit longer to heal and get back to normal. Adhesive capsulitis, or frozen shoulder, may be a result of trauma and immobilization, which will result in abnormal arthrokinematics and osteokinematics of the shoulder complex. It may be considered primary in origin, in which that is an unknown etiology, so we don't know why it occurs. It does occur more often in females in the ages between 40 and 60. But then also the secondary type of adhesive capsulitis is a result of trauma and immobilization that lead to a tightening of that joint capsule. Clinical management of this condition is going to be early intervention, especially the sooner that the patient arrives in therapy after a frozen shoulder, the more successful they will be. A lot of times, because this is usually a gradual or insidious onset, especially with the primary type. Patients don't actively seek medical attention right away and will often just avoid using the arm, which then progresses further into more limited range of motion. You are definitely going to want to be doing joint mobilizations. And again, with this being a restriction of the joint capsule, we are going to see a capsular pattern in limitation. So you're going to see most limited and external rotation, followed by abduction and then internal rotation. So you would want to do joint mobilizations that are going to increase each of those motions. So if we're talking about external rotation, what is the direction of our joint mobilization? That is correct. It's going to be an anterior glide for our joint mobilization. We're also going to want to be doing modalities for pain, and also using modalities to heat up the tissues so that we can do some stretching. And then we'll be wanting to do strengthening through active range of motion, isometric exercises, and then leading up to resistive exercises. This can take a long time for it to heal, especially if we've had a longer time for it to progress into a frozen shoulder. Shoulder bursitis is going to be an inflammation of the bursa, often due to overuse. Our patient is going to present with tender palpation over that inflamed bursa. They're going to have pain with both active and passive range of motion. This is important to distinguish. So because the bursa is not a contractile tissue, it is going to cause pain whether the patient actively moves themselves or you as a therapist passively puts them through the motion. So they will have pain with both active and passive range of motion. So what is the clinical management for this patient? Again, we're going to begin with modalities to decrease the inflammation. The physician may prescribe NSAIDs or give a steroid injection to decrease that inflammation as well. In therapy, you want to avoid any activity that reproduces the pain. So we will be doing a lot of isometrics as well as range of motion and strengthening in that pain-free range of motion until the inflammation can subside. Recovery for this is often 4 to 6 weeks. One of the most important things though is if that patient can truly rest. So if this overuse is coming due to what the patient is required to do for work or maybe a recreational activity, is that patient truly going to be able to rest that shoulder and allow that inflammation to decrease? In lab, we will be reviewing the goniometric measurements for the shoulder complex, as well as the manual muscle testing for these muscles. And we will also then try to do some clinical case studies for the conditions that were discussed in this PowerPoint and designing specific treatment plans based on the diagnosis.